What's up, FRT community? So, video today over tracheostomy tubes. This is a big subject. It's a lot of information you need to know, but we're going to try to break it down for you here as simplistically as possible so you have a good understanding and you mainly feel more comfortable working with trach tubes. Essentially is what my goal of this video is. And I don't want you to kill somebody. So I'm going to give you some big bullet points to say, don't do this. And then I'm going to give you some information that just says, hey, remember, keep these things in mind when you're working with trach tubes. Okay? Now, I shorten it to trach tubes. It's actually a tracheostomy tube. We know that the procedure of inserting and of placing a tracheostomy tube is called a tracheotomy. This is actually the procedure of creating the incision in a person's neck that leads to their windpipe. The opening is then called a tracheostomy. We typically refer to that opening as the stoma. And then we put a tracheostomy tube or a trach tube inside of that tracheostomy or inside of that stoma. Now that's where we're going to kind of start, just some basic terminology. Now before I get any further into this, I want to give you guys some real world just encouragement in what you're doing and what your goal is and on this journey to become a respiratory therapist. This is specifically for students. Today I worked with 3 fifth semester students. They'll be graduating in less than 3 months. And I want to give them praise because we started our clinical rotation this morning at 6:30 and we wrapped it up a little before 2 o'clock. And my point in telling you this is that we worked from 6:30 to about 1:30. So basically 7 straight hours without a break. Now, I don't always push my students to work without a break. I actually try to get them a break around 10 or 10:30 or so. Let you just get off your feet, let your brain work, rest for a minute, and get you a quick bite to eat and then come back. It's typically what we do. But today it didn't happen. Now, the reason I'm pointing this out is because I didn't have a student one verbally complain out loud to me that they didn't get a break. And I think that's a good sign because that tells me I'm working with students who maybe didn't like the fact that they didn't get a break. And I'm sure when they were with their fellow classmates, they were probably saying, I'm hungry and I need something to eat. But they didn't complain about it to their clinical instructor. And what that shows me is that they understand the reality of working as a licensed respiratory therapist. Now, the reason I'm sharing this with you guys is that you need to understand that. You need to understand that there's going to be days when you go into your shift, and maybe most days by 9 o'clock, you're able to get a break and get a little bite to eat for breakfast, and then get going back on the rest of your day. But not all days are like that. There's going to be days where you clock in at 6:30 and you work till 1:32, 2:30, and you go, I haven't even had a break. I haven't even had time to stop and go to the restroom. And you need to be prepared for that because that's what healthcare is. That's what it's about. The needs of your patients trump the needs of you. So you need to go into that clinical rotation. You need to go into that shift knowing that it's a possibility. And what this will do is set you up for success because you'll know I need to put something in my stomach before I head out of the house, or maybe eat a banana on the way to clinic or on the way to my shift. I got to get something in my stomach. I need to hydrate. I need some water. Whatever it needs, you need to do before you get to that shift to ensure that if you have one of these days like we had today, to where we did not have time for a break. Each student had 3 separate patients. That may not sound like a lot to some of you. Like, well, I wish I only had 3 during my clinical rotations. But as 5th semester students, we've worked up from 1 ventilator patient to 2 ventilator patients to 3 ventilator patients. And you're having to learn how to manage these patients. Now, we were ready for a break. It was about 10 o'clock, and I was ready to say, hey, you guys go get you a bite and come back. But guess what? We had a patient blow their endotracheal tube cuff. So we had the bronch and Cook's exchanger to replace that endotracheal tube. And while that was happening, somebody said, hey, we need to go to MRI. So we were off to MRI. And then somebody said, we need to extubate bed 35. So we went and extubated bed 35, students doing different things. And so it just happens sometimes like that. Sometimes it just falls apart, and I want you to be aware of it, okay? So those are the days that you probably learn the most. and that you look forward to. But those are also the days that make you extremely appreciative of the days when you get to sit down at 9 o'clock and take 15, 20 minutes to yourself to get you a bite, drink you a cup of coffee, and then go back and finish your day. So just big props to my students today, and encouragement to all of you guys, knowing that it's going to be rough some days. Stick it out and know that you're doing the work of sick people, and that's rewarding in itself. Okay, so here we go. Tracheostomy tubes. We already went over some basic terminology. What I'm going to do here is just draw a set of lungs up here on the board. They're not anatomically correct, so don't worry about, if they're anatomically correct. Oh, I need another main stem right here, don't I? Okay, so here's my lungs. Here's my trachea, my carina, my two main stems, and then my lungs, obviously. And I'm going to make this just a little longer, and I'm just going to write VC up here, and this is just stating this is where the vocal cords are. Okay, so when you understand when we're talking about a tracheostomy tube, this is what we're talking about. The tube is placed above the carina, but beneath the vocal cords. So a hole is made in the neck. That's the tracheostomy. And a tube is put into this region. Okay, so here's our trach tube. Now typically there's a plate that is on here, kind of a faceplate that just keeps it from sliding too far in and allows you securing devices to secure the trach to your patient. And then you have an inner cannula that might be on the outside of here. They've changed over the years. Now they slide on the inside. They used to alligator clip on the outside. Now they're more on the inside. It doesn't matter. This is just representation of an inner cannula. Now, when we talk about tracheostomies, we're talking standard tracheostomy tubes here. Most of them have a cuff, which means they have a pilot balloon. Okay? So this pilot balloon is what you control this cuff pressure with. Now, this is no different than an endotracheal tube. If you have an endotracheal tube, you're shooting for 20 to 25 milliliters of mercury, 20 to 30 centimeters of water pressure. Try not to max 30. If you need more than 30, 40, 50 centimeters of water pressure, you probably have too small of an endotracheal tube. Same story with tracheostomy tubes. Same cuff pressures, 20 to 25 milliliters of mercury, 20 to 30 centimeters of water pressure. Holding at that 30 centimeters of water pressure for what they show as best outcomes. That reduces the amount of biofilm aspiration, but also occludes the airway without impeding blood flow, lymphatic blood flow to those regions. Okay, so they found that 30 centimeters of water pressure is a safe cuff pressure. Okay, they've kind of gotten away the minimal leak technique and a minimal occlusion volume where you leave a little bit of a leak. According to Egan's, it's kind of fallen out of favor due to the higher rate of ventilator-acquired pneumonia associated with the leakage in that little area around the cuff where biofilm can leak down and cause infection. So, just real quick off the sides there for a cuff. Now, this is what we would call a cuffed tracheostomy tube. This could be an 8, a 6, a 4, the various sizes, just like endotracheal tubes, okay? The most common is probably the Shiley, and that's what this is representative of. But you need to understand also that you can also have an uncuffed tracheostomy tube. Now, when would you need a cuffed versus an uncuffed? Well, the answer to that is anytime you are going to require, your patient is going to require mechanical ventilation, positive pressure therapy, you have got to have a cuff on your trach tube to create the seal in the airway so that the positive pressure goes down and out instead of going down and up and around the cuff. So that's your answer. If you need positive pressure therapies or mechanical ventilation, then you got to go with a cuffed tracheostomy tube. If you have a patient who's going home with a tracheostomy tube and there's no need for mechanical ventilation, then there's no need for them to have a cuff. They're more than fine to go home with an uncuffed tracheostomy tube. Okay, so I hope that makes sense. Now, from here, things kind of start to get a little, I'm going to kind of erase this a little bit just to clean it up a little bit. From here, we can break tracheostomy tubes down even further. We can talk about fenestrated versus unfenestrated. Now, when you say fenestration, a fenestrated trach versus a non-fenestrated trach or an unfenestrated trach, then what you're talking about, this term fenestration refers to a hole in the trach, right about here. The purpose of a fenestrated tracheostomy tube is to promote and to enhance more airflow through the upper airways. So obviously we're not talking about a patient who needs mechanical ventilation in that time. So if you have a patient who needs mechanical ventilation, you would not want a fenestrated tracheostomy tube because the air would come in and up and out the fenestration. Instead, what you would want is a non-fenestrated tracheostomy tube, a trach tube that does not have this hole in it. Now, here's where it gets kind of tricky. What if you have a patient who requires mechanical ventilation at night, but during the day they're off the vent and they go onto a speaking valve, which is what my next point of talk is. My next talking point is talking about speaking valves. If that's the case, then a fenestrated tracheostomy might be the best choice from you. But you have to understand that you have to have a cuffed and a fenestrated trach. The cuff would allow you to mechanically ventilate the patient at night. And what you have to do during nighttime and mechanical ventilation times is you have to place a non-fenestrated inner cannula. So you'll have an inner cannula that comes in here that is not fenestrated, and it'll slide in right like this. So now you can mechanically ventilate the patient because the fenestration is now voided by the non-fenestrated inner cannula, and you have a cuff, so you have a seal, and now you can mechanically ventilate your patient. So I hope that makes sense. Now when this patient at night comes off the mechanical ventilator, and during the day they go onto a speaking valve, okay, so I'm going to write speaking valve here. Now, us old timers, we refer to this as a PMV. PMV refers to the maker of the original speaking valve. This was a patented device that was under the name of the Passi-Mirror valve. We all refer to it as a PMV valve. Well, the patent has expired, and now other people, such as Shiley, are making just standard speaking valves. They all work underneath the same principle. So that's important to understand. So this person at night wears a non-fenestrated inner cannula with a cuffed trach, and we mechanically ventilate them. During the day, we take the non-fenestrated inner cannula out. We put a fenestrated inner cannula in. We drop their cuff down, and we put a speaking valve on the end of this. Now, what this speaking valve does is it has a one-way valve in here. Okay? So when the patient inhales, air comes in and down to the airways. But when the patient exhales, the pressure of the gas coming back up closes this valve, and air passes up past the vocal cords, and this allows them to speak. So this is why it's called a speaking valve. Okay? That's the scenario if you need mechanical ventilation at night and speaking valve during the day. You got to have a cuffed trach. A fenestrated trach, while it's not necessary, would help. But you have to understand that if you use a fenestrated trach during the day to aid speaking, that when you flip to mechanical ventilation, you have to insert a non-fenestrated inner cannula, or air will just leak out up your past your upper airway during mechanical ventilation. We don't want that. Now, as I talk about, I kind of got a mess here, but I'm gonna do the best I can. As I talk about the fenestrated tracheostomies here, remember, you have a hole right here, right? What do I need to remember? Do not suction a fenestrated tracheostomy tube with a fenestrated inner cannula, because you run the risk of this suction catheter going in and out and perfing the posterior wall of the trachea. That's bad. You don't want that. So anytime you have to suction a fenestrated tracheostomy or a tracheostomy tube, ask yourself, do I have a fenestrated inner cannula in? Because if I do, I may cause harm to my patient, because that fenestration will allow my catheter to slip through and possibly cause complications. So what should I do? I should probably put a non-fenestrated inner cannula in, And that'll guide my suction catheter down to my carina to where then I can suction and get all those secretions out for my patient. Okay? So that's where we go when we're talking about fenestrated versus non-fenestrated intercannulus and tracheostomy tubes. And I'm going to redraw this because there's a key here I need to show. Now, I told you I was going to tell you something that might potentially save your patient's life. You put a speaking valve on your patient. One of the top things as a respiratory therapist you have got to understand is that speaking valves and cuffed tracheostomies create a potential problem that could turn real ugly real fast. And the reason being is this. I told you that when you have a speaking valve on, when the patient breathes in, the air comes into the lungs, right? The patient takes a breath. But then when they exhale, the air goes back up past the vocal cords. If you have a cuff that remains inflated and you put a passing mirror valve on, air will come in as it's supposed to, but air will not be allowed to go out. So every time your patient takes another breath, and they're going to develop distress very, very quickly, because with every breath, there's more volume coming in, but the volume can't get out because the cuff being up won't allow it to go up past the vocal cords. The valve on the speaking valve is shut. So the air has nowhere to go except to stay in the lungs. So the first breath comes in and the lungs go like that. The second breath comes in and the lungs hyperinflate. They get bigger. They try to exhale, they can't. They take another breath, the lungs get bigger. And as soon as you know it, before you can even think about it even happening that quick, the patient has developed a pneumothorax. And a tension pneumothorax at that. And they're crashing very, very fast. So you need to understand, cuffed tracheostomies and speaking valves create a potential problem. Do not ever put a speaking valve on a patient with a cuffed tracheostomy tube with the cuff inflated. Now, you can deflate the cuff, which is what you should do. And that's fine. But you want to be able to relay this information to your care team, to your nurses, to your patient. They need to understand that this cuff is down because the patient's on a speaking valve and it needs to stay down. If the patient needs to go back on mechanical ventilation, then we need to come in, take the speaking valve off, inflate the cuff, and put them back on a ventilator, okay? So do not let that happen to one of your patients. Make sure that you always have your cuff down on a patient wearing a speaking valve. It's a must, guys. That's like one of the top. You'll probably have at least one, maybe two questions on your TMC exams and maybe your clinical simulation exams regarding this idea right here, okay? So make sure you do that. Now, beyond that, there's a couple of outliers that I want to make you aware of. I'm going to try to clean this up again because it's a mess up here. But this is the way we teach, guys. This is the way we show it. We say, let's go. Let's make a mess of it, and we'll clean it up, okay? So we've got our airway here. There's another trach, and I'm not talking about the passing mirror valve anymore, so I'm going to take this down, okay? There's another trach that comes in like this, and it has a foam cuff. Now, this is called the Bavona foam cuff tracheostomy tube. Now, what makes this unique is that the foam cuff inflates to ambient pressure. So there's a cuff at the end of the trach. There's a cuff. There's a pilot balloon. It's a big red pilot balloon with another little port right here on it. Okay, it's red for a reason. You need to think about this. Okay, this trach functions differently than all other trach tubes. Because other trach tubes, the Shileys, you have to inflate the cuff. And then if you want to take it down, you have to deflate the cuff. The difference with the Bavona foam trach is that when this port is open to atmosphere, your cuff automatically inflates. To deflate it, you have to actively deflate the cuff. And then you have to close this off with a cap. and that'll keep air from coming back in to reinflate it. This is probably the single most dangerous trach you could have on a patient with a speaking valve. I would not recommend it, because a simple opening of the pilot balloon, the foam cuff inflates, and you're on a speaking valve, and now you got the scenario we created just a second ago, right? So you've got to understand that the Bavona foam trach is the opposite of everything else. It inflates automatically. You have to actively deflate it and then close this to ambient pressure to prevent it from reinflating. So keep your eyes open for the Bavona foam tracheostomy tube. You don't see them a whole lot anymore, but I still feel like my duty is to share this information with you. Now the other one is one that you might see a little bit of if you're working in the ER, is what we call the Jackson trach. This is the metal trach. Now what's unique about this is you have a patient that comes in with a home Jackson tracheostomy tube. They come in, they're in respiratory distress, and you have to manually ventilate this patient. Or you have to bag them, and then you're going to put them on a ventilator. Well, guess what? There's a special adapter that has to come with this Shiley that makes it compatible to adapt to a ventilator circuit or an ambu bag. So if you don't have that adapter, you got to get that Jackson trach out, and you have to get a cuffed, non-fenestrated tracheostomy tube in that patient so you can provide mechanical support for them. Okay, that's the Jackson. It's the metal trach. Doesn't have a cuff. It doesn't have an adapter for mechanical ventilation. It has an adapter for mechanical ventilation, but it doesn't stay attached all the time. So you have to have that piece if you need to mechanically ventilate this patient. Don't be caught off guard in the ER if that setting shows up. Okay. Now the last thing is, and then I'm going to end it here. I'm going to give you a few pointers at the end, but the last thing is there's these tracheostomy tubes that we call XLTs. So you have a Shiley XLT. This is an extra long trach. Now what you need to know about the extra long trachs are this. I'm gonna erase this so I have more room to show you. So this is the XLT. Write this down and do not forget this. Okay, this is a difference in exceptional and average respiratory therapists. XLT trachs come in two different types. You have the proximal XLT and the distal XLT. Now remember, if we look at a tracheostomy tube, and a standard tracheostomy tube looks like this, and you have a cuff here, okay? When we say proximal XLT, we make this part longer. So it gets longer from here to here. This is proximal. This would be ideal for a patient with a lot of adipose tissue, or another way to say it would be a short, really fat neck. Okay, a lot of adipose tissue, and you need more distance from here to here to make your way into the trachea. Okay, because of all of this adipose tissue. That's a proximal XLT. Now, a distal XLT adds distance at the distal end. So you have your cuff, and this additional area here is your distal XLT. This would be indicated for a person that's typically very, very tall with a very long neck and a very long trachea, and a standard trach tube doesn't create a seal when you inflate the cuff to 30 centimeters of water pressure. Why? Because the top of the trachea is wider than the base, and as you move down the trachea, it gets smaller as you move down. So if you don't want an ill-placed tracheostomy tube that's too high in your patient's trachea, then they may need a distal XLT. Now, why is Joe telling me this? The answer is simple. If your patient has an 8.0 proximal XLT, then for that patient, there should be the same size and one size smaller spare trach tubes in the room in case this tube comes out. Now, if all you do is grab an 8.0 XLT and you don't pay attention to if it's proximal or distal, then you may have a spare 8.0 distal in the airway. In your room. And that won't work for a patient who needs a proximal. So you got to make sure when you're putting your spare trachs in the room, which is one of my finishing points, always have 2 spare trachs in the room, the same size and one size smaller. So if you have an 8.0 Shiley, you want a spare 8.0 and you want a spare 6.0. If you can't get that 8.0 back in, then you can try that 6. That's why we go the same size and a size smaller in case a tracheostomy tube comes dislodged or comes out completely. Okay? If you have an 8.0 proximal, then your spare trach should also be an 8.0 and a 6.0, but they should be proximal XLTs, not distal XLTs, and it's easy to overlook it and not know it if you don't know it. Okay? So make sure you understand when you hear XLT, ask the question, is it proximal or distal? And let the respiratory therapist answer the question, see if they know for themselves. Okay? So the final points that we're going to make here are very, very simple. All of your trach rooms should have 2 spare trachs. I already kind of talked about that. I'm just going to say 2 spares just to save time. So 2 spares, same size and one size down. You should also have an ambu bag in all of your trach rooms, every single one of them. You have an airway that can become dislodged. It can be pulled out. It can be occluded by thick mucus. And you may have an emergency situation on your hands. The last thing you want to do is have to leave to go get an ambu bag. And then the other thing that you're always going to want to have in a room is the obturator. Remember, the obturator is the device that goes inside the trach tube. So this is your trach tube. The obturator goes inside and has a rounded point on the end of it. And this rounds these edges so that when you insert a tracheostomy tube, you don't tear tissue because of the rigidity of the tracheostomy tube without the obturator. So the obturator creates this rounded edge that will allow you to reinsert the tracheostomy tube in the case of it being removed accidentally or dislodged. Okay. The last thing to remember is this right here. If a patient ever has a dislodged tracheostomy tube or one that comes out and you have to replace it, always be on the lookout for false tracking. This is when, instead of putting the tracheostomy tube back into the patient's trachea, it slides down into the soft tissue surrounding the trachea. Now, it looks like it's positioned. It actually doesn't. You can kind of tell it's kind of crooked. It doesn't look right. But your patient's still breathing. They may be in distress. But it's your job to ask yourself, am I in the airway? If you false track and you start to bag, you're immediately going to know it because you're going to see subcutaneous emphysema develop immediately. So ask yourself, am I in the airway? A good practice to get into, just like when you intubate a patient, would be to, if I need to replace a person's tracheostomy tube, maybe I should have an end-tidal CO2 detector with me at that time. So I go into the airway, I check for my end-tidal CO2 return. If you're false tracked, you won't get end-tidal CO2 return. Okay? If you're in the airway, you will achieve that end-tidal CO2 return and you'll go, this is what I was hoping for. My airway is in an appropriate place. My patient assessment following the replacement of the trach tube, everything looks good. And my patient tolerated the trach change out correctly. Okay? There's a lot more things I could talk about when it comes to tracheostomy tubes, but those 25 minutes, I'm at 30 minutes now. The first 5 was about clinicals. So that 25-minute breakdown of tracheostomies is about as simplistic as I can do it in a reasonable amount of time. Okay? If you have any questions over anything that I stated, please send me a comment down below. I will respond. I promise you, I will respond as quick as I can, and I will try to clarify your confusion or your misunderstanding on the topic. The last thing I want to leave you with is this, guys. Respiratory therapy school can be complicated. Some of the things that you're learning are very challenging. You may find yourself confused. And when you're confused, keep going because you're about to learn something. Best wishes, guys.